start introducing. All right, well, welcome everyone. I am so happy to have you here today. My name is Liz Aparicio. I'm an associate professor of behavioral and community health and also the director of the University of Maryland Prevention Research Center. We're a translational research center that we focus on four main areas in prevention science: substance use, mental health, violence prevention, and sexual and reproductive health. And I am so thrilled that you're all here today for our first in a four-part series of our speaker series. So very excited to have Dr. Noah Triplett here, who'll be presenting on supervising trauma-informed or trauma-focused cognitive behavioral therapy across contexts and giving examples from both Washington State and Kenya. So just by way of introduction, Dr. Triplett is a licensed clinical psychologist and one of our faculty affiliates at the PRC. He is also an assistant professor in the Department of Behavioral and Community Health at the University of Maryland, College Park. His research focuses on improving access to high quality mental health and substance use services for youth through community engaged and implementation science approaches in the US and globally. Dr. Triplett is an expert in trauma-focused cognitive behavioral therapy, or TFCBT for short, and maintains an active clinical practice providing evidence-based care to youth with co-occurring mental health and substance use concerns in rural Maryland. His work has been supported by the National Institutes of Health and published in leading journals on clinical psychology and implementation science. So I will turn it over to you, Dr. Triplett.
Thank you. Yes. Give me a second to share my screen here. And Liz, could you just give me a thumbs up that you see the screen and not notes? Okay, great. Thank you. All right, so thanks for having me. I'm excited to be here, and I hope that we can make this pretty conversational and sort of like a workshop and less like a lecture. And so I'm excited to present about some of the graduate school work I did on trauma-focused cognitive behavioral therapy, and the work that we did to make that more accessible and also effective. So ranging from some work in Washington State and then also in Western Kenya. So to start, I'll provide a little background on implementation science and its relation to trauma-informed interventions or care. And then I'll explore two implementation case studies, one being the STEPS study or Supervision to Enhance Practice study, which is an NIMH-funded research study in Washington State. And then the second being BASIC or Building and Sustaining Interventions for Children, which was another funded research study in Western Kenya. And then throughout, I'll try to have some hands-on activities. I think it'll be more discussion than anything else. So we'll try to keep it conversational. I'll, have some chances for people to put things in the chat, quick reflections. And so hopefully it won't be just me talking about implementation research. We can also do some thinking together. So I'm kind of curious. I wasn't sure going in who would be here today. So I think our group is a pretty good size, and I know some other folks, but of folks that are here, maybe since we only have about 9 people, you could even just come off mute and say kind of like, how would you describe your role? Are you more of a researcher, a practitioner, a trainee? Who kind of has done some clinical work before? I'm curious.
I can get it started. So I'm a researcher primarily now, and before coming into academia, I did direct practice for about 10 years.
I can go. I am a faculty member and researcher, and my postdoc is in mental health. So I've never done any clinical work, but I have training in that area.
I can go next. So, my name is Maya, and I'm currently a graduate student, and I'm doing my final capstone project on mental health, specifically maternal mental health. So, I'm just curious to learn about all types of research that I can. So, thank you for being here.
I can go next. I am researcher faculty that works on substance use, mainly nicotine and cannabis, and it's related to like the mental health in some areas that I work. And I'm very excited to learn more about your work. Uh,
I can jump in. I'm a researcher, faculty member, and I've done some work in mental health, and specifically working with clinicians and competency training for clinicians.
Hi, this is Kathy. I do not have any experience. I'm the director of graduate studies and interested in learning more.
Hi, I'm not a clinician researcher. I have worked with clinicians in the past, but not in the mental health space.
Okay, great. And sorry to put you all on the spot like that. But this is helpful because I think, well, one, I feel relieved that I made this more of a research talk and less of a clinical talk too. But it'll provide, I think, a mix of some clinical focus, but it'll be a lot more about the research and the research findings. So um, hopefully you all will, yeah, I'm sure you'll all have great reflections on it. So. All right. I'm sure this is nothing new for any of us in the room, but we all know that there's this tremendous burden of mental health disorders and substance use disorders around the globe. Um, and there are kind of treatment gaps in every area of every country, but we know that there are larger treatment gaps in lower resource settings, like low to middle income countries such as Kenya, or rural areas like the Eastern Shore of Maryland, or even in some urban pockets as well. We also know that there are major gaps in access to evidence-based mental health care around the globe. So even if someone does have access to a clinic, they may not be receiving care that is evidence-based or care that is proven effective for what they're presenting for. So, at the same time that all of these mental health disparities are widening within and across countries, so we know that access is not evenly distributed, both along demographic lines and racial and ethnic backgrounds, but also age. So, in recent estimates, less than 10% of children in low income settings may receive any kind of mental health treatment. And then, particularly, even in high income countries, rural and minoritized communities face even bigger access barriers and are less likely to access needed care. At the same time that we have these rising global financial inequities and social inequities, we also see kind of in correlation with that an increasing exposure to traumatic events around the globe. So the global burden of trauma exposure is increasing from increasing conflict, displacement, poverty, the effects of climate change, and also community violence. I think, we all see this daily. If we look at the news or, are somewhat tapped into what's going around the globe, of course, in one way, we're just more aware of things that are happening globally. But also, I think that rising inequities around the globe has led to more people experiencing trauma or more people being exposed to potentially traumatic events. And unfortunately, youth often bear a disproportionate share of these experiences, and a lot of youth around the globe are increasingly exposed to potentially traumatic events and therefore increasingly at risk of developing post-traumatic stress disorder or related sequelae. The plus side is that we do have strong evidence-based treatments like trauma-focused cognitive behavioral therapy, or TFCBT, which has a lot of evidence for reducing PTSD and grief among youth. There, I think, are more than 15 studies, 15 randomized clinical trials across countries, across populations of a strong racial and ethnic mix, supporting the effectiveness of TFCBT. However, most of this research occurs in controlled settings, often excluding rural, low resource, or culturally diverse populations. And they may be difficult to implement, or as a result, TFCPT may be difficult to implement in settings where most youth access their care. So around the US, most youth or most low income or minoritized youth will access their care through a robust community mental health system, which primarily serves Medicaid or low or uninsured individuals, and has been established by community block grants previously. So, as a result of this realization that most folks will access their care in these sort of lower or under-resourced community mental health clinics, the field of implementation science has sort of, or sorry, and despite this, proven interventions will often fail in these real-world systems because they are typically chronically under-resourced. And so the folks that go to work there, they may be working there so that they can receive supervised hours to get licensure, but they often, are juggling large caseloads. They don't receive appropriate training or support from their employers because their employers don't necessarily have the financial resources to provide them with that. And so they're juggling a lot by no fault of their own. These clinicians are often feeling unsupported. And so the idea of learning a new intervention or receiving specialized treatment in something like, or specialized training in a treatment like trauma-focused cognitive behavioral therapy becomes especially burdensome. So as a result of that, the field of implementation science came to be in the early 2000s or perhaps earlier, thinking about how do we move research into practice. So we have all of these great interventions like trauma-focused cognitive behavioral therapy that have been tested and proven in research trials, but often aren't used in routine practice. And there were some early papers from folks like Anne Garland who sort of classified like what is happening in community mental health. And we learned that a lot of times in these community mental health settings, folks were using treatments that may or may not have an evidence base, but we're also just doing a lot of case management and supporting a lot of social needs and doing a lot of other sort of wraparound care that didn't leave much time or space for evidence-based treatment. But trying to increase access to evidence-based care led to this big push towards implementation science and a focus on implementation outcomes. So understanding what is the feasibility truly of delivering trauma-focused cognitive behavioral therapy in a chronically underfunded mental health clinic. What is the sustainability of that? How can we ensure that people actually continue using it if something like an implementation effort or an implementation research trial has ended? And what is even the acceptability of it? Do clinicians on the ground working in these settings actually even like this treatment that's been developed and tested so rigorously in sort of this controlled research setting? So, as part of implementation science, it's led to this big focus on understanding kind of what are the processes required of moving an intervention into practice, what are the determinants of doing so, what are the barriers and facilitators, and then what strategies can we rely on to increase the uptake or increase the implementation of those interventions, which then directly impacts both our implementation outcomes. And then we hypothesize later on that will improve service outcomes. So, the extent to which people are actually receiving safe and effective care. And then also client outcomes. So client satisfaction, but also impacts on client symptoms and function. So really it all rests, I think, importantly, this is a big assumption that implementation science makes often. It rests on this assumption that something like trauma-focused cognitive behavioral therapy is better and more effective than what people would be receiving otherwise. Which I know is an assumption because I think that is something worth unpacking that we can maybe talk about a little later when I present some of the clinical results from some of our implementation trials. So it begs this question of thinking about implementation strategies. How do we bridge research and practice? There are a lot of different ways to do this. People have tried a number of different approaches or levers, including focused on training, TFCBT. What we've learned is that just training intervention in an intervention, sort of training and praying or hoping, doesn't tend to work as people will attend a training and then they're unlikely to continue to use an intervention or sustain use of an intervention or even initially use an intervention after a light touch training, which has led a lot of folks to focus on things like clinical supervision or clinical consultation. And so, in addition to training, supervision or consultation is this prolonged, ongoing relationship that someone may have that can reinforce potentially any new interventions that are being learned or applied. So clinical supervision is incredibly commonplace in mental health training. It is required by, I think, every licensing board or every accrediting agency that mental health trainees have some level of clinical supervision. And so it is something that's nearly ubiquitous, even in community mental health settings. So even in these settings that have relatively limited resources, folks are continuing to get regular clinical supervision. And there does not seem to be a substitute for expert consultation, supervision, and or feedback for improving skills and increasing adoption of interventions. So clinical supervision is a ubiquitous, accessible, and potentially incredibly effective way of increasing the use of something like trauma-focused cognitive behavioral therapy. Um, but it has historically been one of the least studied implementation strategies. So despite how often it's used, it has not received much attention in the literature, and relatively greater attention has been devoted to studying supervision in children's mental health, though, with the promising findings that clinical supervision, of course, is nearly ubiquitous, but we don't really know what the effect of supervision is. And this kind of sets up where a lot of my research in graduate school focused, which is why does supervision matter? So we know that supervision, or we hope that supervision directly shapes treatment fidelity, clinician confidence, and treatment quality, especially for complex interventions like TFCBT. If you're meeting weekly with a supervisor, the same way you would meet weekly with your grad advisor or weekly with your research mentor, you hope that you are imparting some skills there, that you are improving the quality of research that is happening, and building confidence among your trainees. But this process of supervision and what actually happens in supervision is sort of understudied. So people approach supervision in very different ways. There is an evidence base to supervision in the same way that there's an evidence base to mentoring, but people may or may not be aligned with the evidence base. Um, and so, despite the promise of supervision, kind of this is what I was mentioning, it's often applied inconsistently or unsystematically. So, we know that there's an evidence base for it, but we may not be following the evidence base for it often. And so, much of my research has then focused on what is the impact of supervision and how can we quantify the impact of supervision on something like a mental health treatment or a substance use treatment. And then how do we improve access to and quality of supervision? How can we align supervision with the best research out there while also improving access to it? And then, because I'm particularly interested in the affective side of things, how do we also understand the supervisory relationship or the supervision process? So there's something special about the relationship that a supervisor might have with the trainee. The same way that you want a strong relationship with your research advisee, a clinical supervisor would want a strong relationship with their clinical supervisee. So this sets up the first case study, which was the Supervision to Enhance Practice, or STEPS study. And to set the stage for STEPS, I'm going to talk a little bit about Washington State and what we call the CBT Plus Training Initiative. So across Washington State, beginning in 2009 and running concurrently until now, Washington State has sponsored in training and now online, or in person and now online training and expert consultation in trauma-focused cognitive behavioral therapy, as well as other interventions for common youth mental health problems. So upon kind of realizing and seeing the research on how there was a vast, like, broad array of services being applied in community mental health settings, particularly for youth, Washington State invested in supporting these state-sponsored trainings where they could train community mental health providers in evidence-based interventions for common youth mental health problems. So this is a relatively low cost for clinicians and their community mental health agencies. And they could receive in-person training, typically for about 3 days, and then ongoing consultation. And it started first focused on TFCBT, or trauma-focused cognitive behavioral therapy, and then grew to include some other interventions as well. And as I mentioned, it was focused first on TFCBT, which is a structured short-term treatment for children and adolescents who have experienced trauma. And it combines trauma-sensitive interventions with cognitive behavioral, family, and humanistic principles. So TFCBT is typically delivered in 12 to 16 sessions, or at least in research settings, it's typically delivered in 12 to 16 sessions and includes sessions with both the child, which is defined broadly. So TFCBT can really range from ages, I would say, like 4 to 18, and then their caregiver. And again, it's been supported by more than 15 randomized controlled trials across high and low resource settings. So in the US, but also globally, there's strong evidence for TFCBT. And in the 12 to 16 interventions, TFCBT is guided by what we call the practice acronym. So TFCBT is a phased treatment where we first start in what we call the prac phase. So in prac, it includes a focus on the skills that we think are necessary before doing deep trauma processing. So starting off, you engage youth and their parents in a process of developing psychoeducation or providing psychoeducation. So, normalizing reactions to trauma, common reactions to trauma, and teaching positive parenting practices that support and reward positive behaviors out of children. We also teach youth relaxation skills to reduce the physiological arousal that is common after traumatic experiences. We teach affective expression and modulation, which helps youth to label and manage their emotions. And then we also introduce cognitive coping, where youth can identify links between their thoughts, feelings, and behavior. So this is really important, especially for kids that may experience a lot of self-blame after traumatic experiences, to help them understand how, something that happens to them isn't necessarily their thought, and really start to unpack cognitively this pattern of blaming themselves that may reinforce the traumatic symptoms. After we have completed the initial stabilization or sort of introductory phase, we move into the two final phases, the T or TI phase, which is trauma narration and processing, wherein children actually recount their traumatic experience and engage in some gradual exposure via storytelling. And then following that, they face avoided reminders of traumatic events in a safe and controlled way. The thinking behind this is that the leading cognitive theory for PTSD and its maintenance is that we often avoid reminders of traumatic events, whether that be in person or cognitive reminders, so thinking about the story, and that the only way to face our fears is to approach those memories or approach those avoided reminders in a safe and controlled setting so that our brain can sort of relearn those associations. So rather than thinking I have to avoid cars for forever because of a car accident, I relearn that there is some danger associated with cars. But after repeated exposure to cars without car accidents, my brain will readjust to a more balanced relationship with some sort of avoided reminder of a traumatic event. So after we do, and importantly, I'll call this out, because the theory of or the etiology behind PTSD is so rooted in avoidance in a cognitive model, it's theorized that this is really the main active ingredient of a trauma-focused intervention. But as you can imagine, whether you've been a clinician or not, it's really hard to say that you need to go in and talk to a child about a traumatic event that they've experienced. So, despite there being a lot of theory behind this being an incredibly important element of a treatment, we do know that this is also one of the hardest elements of TFCBT to deliver. And oftentimes, people will avoid, even clinicians will avoid delivering this piece of the intervention. After folks have done that, though, then they transition into a consolidation phase of the treatment where we encourage the youth to kind of share their experience with their caregivers. We coach the caregivers to enhance the level of support that they provide and react in a validating way for the youth. And then we also work to enhance safety and future development by building resilience and also safety planning, because we know that youth that experience one traumatic event are at risk of experiencing future traumatic events. So, with that as our sort of evidence-based intervention that had been trained in Washington State across 10 years, I think, prior to this trial, it laid the foundation for STEPS, which was a National Institute of Mental Health, RO1, so large research grant that was a two-phased mixed within and between subjects design that included an initial phase of a baseline and descriptive study of just trying to understand what kind of supervision was provided in these community mental health centers, particularly as it related to trauma-focused cognitive behavioral therapy. And then fall and how was that or was it not aligned with what maybe the gold standard supervision strategies that we had in the literature? And then following that baseline and descriptive study, phase two actually randomized clinics or randomized providers to one of two different supervision strategies. So we studied the impact of receiving either symptom and fidelity monitoring, so a process where a clinician and a supervisee would just go in and review the symptoms of their clients on a weekly basis and understand where they were in the process of the treatment. So fidelity monitoring, they would just look at sort of a checklist and say, I am in the process of delivering the cognitive coping element of the intervention with this child. So that was one component strategy. And then the second strategy was that plus behavioral rehearsal. So that plus doing role plays around the specific treatment elements. So in phase one, as I mentioned, we examined what happened in the community mental health supervision sessions. So we used audio recordings of supervision sessions. And then we had a team of research assistants that qualitatively coded all of these sessions for content and techniques included. And then in phase two, we looked at two main outcomes. So the first primary main outcome was TFCBT fidelity across phases. So did clinicians in our study deliver TFCBT as it was intended? Did they actually touch on all elements of the practice acronym? To do this, we taped treatment sessions. And then these treatment sessions were reviewed by trained study coders who were naive to study condition. And they looked at both adherence to the intervention. So was each element of TFCBT delivered? And then if it was delivered, how extensively was the TFCBT component delivered? So did they spend 1 minute doing something like a trauma narration where they had the youth very briefly tell them what happened to them and then they breezed right through it? Or did they spend a session reviewing a trauma narrative where they had the youth describe it and then added details about what was happening around them and how they felt in their body and what emotions they felt? And so we were able to look at both adherence, but also even beyond adherence, just how extensively or maybe how well was the component delivered. And then in addition to looking at the fidelity to the intervention, we also wanted to be sure that we looked at the clinical outcome. So did kids actually get better? And to do that, we looked at youth-reported post-traumatic stress symptoms and then guardian-reported post-traumatic stress symptoms. Results from phase one indicated that typical supervision practices in community mental health often include varied content. So this was, I think, a big finding, which for folks that might have worked in community mental health before or have any experience working with community partners before, or working in community settings before, it's probably not that surprising. We found that oftentimes in these under-resourced settings, one of the last things that we're worried about is the intervention itself. That's maybe an exaggeration, but oftentimes other topics, including managing client crises or just providing case management, often takes priority in supervision sessions. So we see that I don't have the key, or I have the key here, but not really the methodology. But in 27% of our sessions, there was a high degree of time allotted to other topics and case management. So this is thinking like Maslow's hierarchy of need. If my client comes in and they don't have a safe place to sleep that night, then I'm going to engage my supervisor to think about how can we make sure they get somewhere to sleep. Or if they don't have any food to eat, then I'm going to ask my supervisor for brainstorming about where I can refer them or some food banks that might be working or might be able to support their needs. So this really was the biggest focus of our supervision sessions and by a long shot. After that, treatment engagement was a big focus. So understandably, if folks are struggling with where they're going to sleep or what they may be eating that night, it's hard for them to actually show up for their appointments. So we saw a fair bit of time dedicated to helping brainstorm or problem solve around how to ensure that people can adequately engage in treatment. And then following that is when it started to get into the more treatment specific things. So exposure, something like a trauma narration, thinking about how do I approach this sensitive topic with youth was the next most common thing. And then it sort of went down from there. Importantly, sort of all the way down here at the bottom, we see that client behavioral rehearsal and clinician modeling were covered relatively infrequently. And what this means is that actually doing a role play, actually having your clinician in front of you say, like, how would you approach this with a child? How would you ask a child to share what happened to them? Occurred relatively infrequently in session. And despite this, we know that this is actually one of a sort of strongly evidence-based strategy to ensure that someone is able to deliver treatment as intended if they are able to see some modeling and actually practice that in supervision. So when they were focusing on these topics, we often saw that in addition to topics, we looked at the evidence-based strategies that might be happening. And oftentimes we saw in supervision that supervision tended to be a lot of supportive listening. And there's nothing wrong with that. I do think that there's a place for supervision to be supportive and it should be supportive. But in the context of a supportive learning environment, there was very or relatively little didactic instruction or providing clinical suggestions relative to how much supportive listening was going on. So oftentimes, supervision had this function of being a place for the supervisee to come in and receive support, perhaps emotionally, around what they were doing in their job, which again, I think there is a place for that, but it also introduces this funny dynamic of like, how do you meaningfully support clinicians in developing their skills and also take care of their emotional well-being without crossing lines or blurring lines. And so I want to pause here just thinking about um, these results and summarizing that in this setting, we know that folks often use supervision in a mainly supportive way or a case management way and not to really focus as much on treatment, despite these all being early clinicians who kind of by their status required supervision to continue building their clinical skills. And so I'm curious, like, what are folks' reactions to this? What does it make them think about in their own work? Or how can we draw the connection to supervising graduate students or supervising trainees or just working with communities in general? And how do you really start to balance focus and skill building with also trying to be supportive emotionally? Yeah, Liz.
Yeah, I really relate to that. I think it's important to have a place where you can provide support and feel supported. Um, but yeah, to be able to like talk through some of the challenges and really kind of get in there, I think it's really incumbent on the supervisor to set that structure because otherwise the supervisee is just going to bring they're going to want like affirmation and just like to be able to talk about the things that they've been through without there being like, this is what I'm really struggling with. What do you suggest? Like, how can we like work this through? So I find that group supervision is a nice place to do that as well, where people can learn from each other. So it kind of takes the pressure off an individual relationship. I don't know if group supervision was used at all in the trial or in your work, but Just curious about that.
Yeah, so group supervision, I think, was sort of site dependent. So we didn't require any level of group supervision. It wasn't one of the things that we looked at in the trial. But I know that some of the participating organizations provided groups or facilitated group supervision. And so that would be, I think, an interesting way to kind of look at this data in a secondary analysis of, does maybe having access to group supervision mean that people were able to focus more on the treatment side of things because they can, I think oftentimes group supervision can be that validating safe space to be like, hey, I'm just frustrated about, the state of the world and what this means for the clients that I'm working with. Um, so I think that would be interesting to look at. But it is, I think, a challenge, and maybe the next results that I'll present will kind of put this into perspective more because you do really want to be supportive. And I think, especially for mental health treatment, making sure your providers are well taken care of is so important. But what happens in supervision does tend to matter. Um, and so, looking at phase 2 of the study, where we actually dug into the clinical outcomes associated with supervision, we had 133 clinicians that recorded TFCBT session data for 258 youth in this trial. So we had a really large sample of, or so in psychology standards, this is a really large sample of youth. And particularly when you start to think about treatment recordings, this becomes a really large sample, especially because this was all pre-AI. So all of these tapes, and I don't have the exact tape number, but I would say probably around 750 tapes because we had on average at least 3 tapes for all of our youth, were coded by hand over the process of this session of this trial. Um, and what we saw across all phases of the trial, so the baseline phase, and then once we introduced our experimental supervision conditions, fidelity to TFCBT was high. So we did see that our clinicians were appropriately delivering TFCBT. And importantly, the results of our GEE or generalized estimating equations indicated that there were no real differences in fidelity for our different supervision strategies. So regardless of if we did some level of symptom and fidelity monitoring, so looking at symptoms, looking at treatment progression, or even doing role plays, we didn't see that that mattered for the fidelity to TFCBT. So no one strategy seemed to win out for fidelity to TFCBT. However, there were some moderators that suggested that something like supervisory alliance, so the relationship you have with your supervisor, might make some bit of difference if you're asking to do something like a behavioral rehearsal or a role play. If you don't really like your supervisor, you probably don't want to do a role play with them. Um, and also, clinician self-efficacy tended to moderate the effect of supervision strategies. So again, if clinicians had higher confidence in their own skills, then they were more likely to benefit from doing something like a role play or a behavioral rehearsal compared to supervision as usual. But this is where I think things start to get interesting. As I said, we had clinical outcomes available for 268 youth. This was a pretty diverse sample, so participating youth were mostly female, and I don't have the numbers here, but they were about 60 or 70% white. And then I think our next biggest racial or ethnic group after that was multiracial, which was around 20% of our sample, and then a smaller breakdown after that, which doesn't seem like a very diverse sample, but it's actually more diverse than what the general state population of Washington State is. And so, for the context, we were working in a pretty racially diverse background. And across all supervision conditions, all phases of the trial, youth and guardians both reported significant reductions in PTS symptoms after receiving the trauma-focused cognitive behavioral intervention. However, we did see that youth in the experimental supervision conditions experienced greater reductions in PTS symptoms. And so, even though there was no evidence to suggest that doing something like a role play improved fidelity to the intervention, what we did see was that across these different study conditions, doing either symptom and fidelity monitoring or symptom and fidelity monitoring plus a role play resulted in larger clinical improvements for youth. And so this is sort of an interesting finding that we weren't necessarily expecting to see, but something, I guess, as a timing effect happened in between our baseline setting here, or baseline here, and our experimental conditions that happened in phase two of the study, where we see that our by happenstance and by, timing effects, the youth that participated in the experimental arm of the study that had the exact same inclusion criteria just happened to have significantly higher PTS scores at baseline. So these youth had more complex presentations and experienced greater symptoms, but also experienced greater clinical improvements. And so there was a significant difference between these slopes here. So there were significant interactions between time and condition. So we know that something about the supervision conditions, or, just by virtue of happening, despite there being a higher PTS score at baseline, they all ended around the same, actually. And so one of our hypotheses is that perhaps even though the supervision conditions didn't improve fidelity, maybe there was something about doing role play or doing a symptom monitoring checklist that helped them work with more acute cases. And that may be potentially explaining the significant interaction that we saw. And then in addition to that, we also explored relations between TFCBT fidelity and clinical outcomes. So did delivering this TFCBT treatment components with greater extensiveness actually result in bigger symptom reductions? And then as the extensiveness with which clinicians delivered the trauma narrative increased, we saw greater decreases in youth-reported PTS symptoms. So again, kind of mapping this around, what we saw is that so each square represents the extensiveness of the trauma narration element. And so each of this is kind of the exposure aspect of the treatment. As folks delivered it with more extensiveness, we saw steeper reductions in clinical improvements, or steeper reductions in clinical symptoms. And so for our most extensive criteria, we saw the steepest reductions here compared to something like a minimally extensive trauma narrative delivery. So I'll present some high-level takeaways here, and then I would love to, after this, kind of have a discussion about like fidelity and how do we measure fidelity, what do we make of fidelity, and if any of you all are doing intervention trials, maybe do a bit of brainstorming about like how you think about fidelity in your trials. So for us, one of our takeaways was that supervision matters and structure matters. So supervision that incorporates fidelity monitoring and practice seemed is more likely to improve skills, or was more likely to result in clinical outcomes or better clinical outcomes potentially. Um, Relationships also matter. So the supervisory alliance may amplify a technique's effect. So trying to do a role play in the absence of a strong relationship with your supervisor didn't give us the expects or give us the outcomes that we hoped to see. Efficiency is key, though, so even short structured check-ins can build fidelity if done consistently. We knew this to be true just by how busy our supervisors were and how busy our clinicians were. We had to do something that was efficient, but also incorporated the best evidence. And then scalability, of course, is a challenge. So even though we know supervision works, we also need to ensure that supervision can actually be accessed. And so this, I think, came up in this trial where we were thinking about how do we, work within the confines of supervision really being limited to an hour a week. And we're not going to say that you shouldn't focus on how to make sure your client's basic needs are met during the supervision, which means that we may just be left with 15 or 20 minutes to really focus on treatment in a supervision. And so how do you work within those confines for more pragmatic models of high quality supervision? So this has been really focused on supervision, but maybe I can just engage you all in a bit of a broader conversation for folks that are doing any level of intervention work in their studies. So whether this be like a mental health substance use intervention, or maybe we can think about prevention as an intervention, I'm kind of curious, how do folks generally think about fidelity in the work that they're doing? And yeah, how are you operationalizing fidelity in your work? And maybe that's something that we could talk through as a group. So, show of hands or just quick reactions, who is thinking about fidelity to their interventions?
I can jump in. In a previous study, it's wrapped up now. We've completed evaluation. We had a fidelity measure because we had outside implementers, if you will. They were part of the intervention design process. But given that there were going to be multiple rounds, we wanted to ensure that one, the rounds were as similar as possible, that the components were covered, that the various aspects of each component were covered, and the right order. And so we had each uh, trainee, it was a training program, fill out a fidelity form after completion, and it was part of the data that we collected. We also collected data from, again, the participants to be able to measure change as well as satisfaction. But it was an important aspect for us to be able to say, yeah, there is change and there's a reason behind this change, that the programs were done um, per standards, if you will.
Yeah. And did you look at like to what extent fidelity actually predicted the outcomes, or just you kind of used fidelity as like a quality check?
It was more of a quality check. We didn't see variation in fidelity because we only had two, like I said, folks that were doing that training. And so it was just like a quality check to ensure dot our I's, cross our T's, that what was happening was per plan.
Gotcha. Okay. That makes sense. Liz, how about you? I know you guys are doing some intervention studies, and yeah, how do you think about fidelity, and maybe do you look at it, and to what extent?
Yeah, fidelity is really important. I mean, we have checklists, like for example, if there's thinking about using it, the place we've used it the most has been in our sexual health intervention for youth experiencing homelessness, and we have different components. So they're offered, this kind of range of pieces that make up the larger intervention. But whenever we do group sessions, because there are different groups that are just like Evelyn was saying, different groups that could be offered by different facilitators to different people, we have these like core pieces that need to be done each time for each sexual health education group because, it just these are like the really key elements. And then we know that there's going to be the beautiful thing that happens in every session, which is that it depends on the people who are present how exactly the session looks, but there are some like key things to make sure happen in the session. And if they don't happen, then we also control for that later statistically. So that's something to know. Like it's not like, oh, you throw that out or the session wasn't valuable because those things didn't happen. You just look at maybe that made a difference and maybe it didn't across the different groups. So it's fidelity is a great thing to look at.
Yeah, I would agree, obviously. Yeah, I think it's a great thing to look at. It's also, I think, interesting from a like an implementation research side of things, particularly in behavioral health, is that we, for a lot of these interventions that we're moving into community settings, there hasn't been a strong evidence base to really suggest that fidelity clinically is that important. And so there are a lot of like meta-analyses that have looked at to what extent fidelity predicts better clinical outcomes. And the evidence base is sort of shaky on that. And there are lots of flaws in the research base for that. Um, but I think one of the reasons being is that a lot of our interventions are developed so theoretically, and we're thinking like, oh, this is the core element. It's important to get this, and we can go back to, actually, this is one of my, I think one of the cool things about the STEP study, because we looked at fidelity to this whole treatment. Um, but the fidelity, how we often operationalize fidelity or think about fidelity, doesn't really consider need, like individual need. And so I think this has been one of the biggest challenges in the fidelity literature, in that like fidelity for the purposes of even our study is to say like out of all 8 components of TFCBT, did you deliver every single one? Were you adherent to every aspect of TFCBT? And then people will take like a composite measure of fidelity and say, oh, I looked, at composite fidelity and related it to clinical outcomes, and for some reason it wasn't related. But that sort of loses all this variation. And maybe I work with a kid who actually like has relaxation skills down pat, like they don't need relaxation skills. Their parents are great, they don't need parenting skills or psychoed, and like maybe they need a little more help with something like cognitive coping. And none of that like tailoring or individualization to actually match a client or community needs, I think, is currently considered infidelity. And so this is like, I love fidelity as a concept, but I think it's important to think about like fidelity and like truly like meaningful, like needs aligned fidelity, and not just like the more paternalistic, us researchers have decided that this is what is fidelity to this intervention, and why aren't you following it? And so I think that's one of the cool things that this study allowed us to do, where we could really say like, okay, so let's look component by component, because we have these breakdowns to say, like, I want to look just at fidelity to trauma narration, because that's what I think is the core ingredient. And that actually predicted outcomes, whereas fidelity to like trauma narration was the only significant effect that we found. And fidelity to relaxation skills didn't make a difference. So, okay, so move forward. I'm thinking maybe right now. I also realized I started this talk and didn't get any bit of water for myself. And so maybe we take a quick break. And then when we come back at, let's say, 3, so in about 8 minutes, I'll transition to the next case study, which looks at kind of scaling up access to supervision, particularly in Western Kenya, and culturally adapting interventions. All right. So we can go ahead and get started again on the second half of the talk. And for the second half, I want to transition to some of the global work that I've done and focus on another study called Building and Sustaining Interventions for Children, or BASIC. So the STEP study was all focused in Washington State in community mental health centers, and we looked at TFCBT. But of course, there's this massive need, as I was saying, everywhere to deliver interventions. And so one of the things that we did was take this same intervention, TFCBT, and think about how we could scale and adapt it for global settings. So again, we know that there is this tremendous burden of mental health disorders and particularly post-traumatic stress disorders around the globe. And most of the treatments that we have, whether they are effective or not, have mostly been developed, or most of the treatments we study, I should say, have typically been developed in Western contexts. And so trauma-focused cognitive behavioral therapy has a strong evidence for its effectiveness, but it was developed by folks in the US, it was developed by people outside of Philadelphia, actually, and it typically has been applied to work with, or historically prior to some of our work, have been applied mostly to work with kids in the US. Increasingly now, there's more global work on it and a lot of work in Puerto Rico as well. But historically, it's been a largely US delivered intervention, which highlighted this need to not only test if it's effective, but what changes might be needed to make it effective. And so I was very fortunate as a graduate student to join this team of folks that had been leading work to adapt trauma-focused cognitive behavioral therapy and also test its effectiveness and its implementation in Western Kenya, Tanzania, and also Zambia. And so I think the first study was around 2009. Yeah. In 2009, my graduate advisor, so this is Shannon Dorsey, she was my graduate advisor, was on a feasibility study where they looked at the feasibility of delivering something like trauma-focused cognitive behavioral therapy. And this was specifically, I think, in Zambia. And then after that, they ran a randomized controlled trial to test its effectiveness across Western Kenya and Tanzania, and then eventually did a large implementation science trial where they looked at how to effectively implement trauma-focused cognitive behavioral therapy after they had established that it was effective in this context. So the three investigative, or the three leads of the investigative team were Dr. Shannon Dorsey, Dr. Kate Wetton, who is at Duke, and then Mr. Augustine Wasanga, who is our Kenyan PI and led at the time ACE Africa, which was our main implementing partner on the ground in Kenya. So the first step in actually using TFCBT globally was to understand how well TFCBT fit the context. And so the first thing that we did was do a lot of this preceded me, was do a lot of qualitative work to understand how people reacted to the TFCBT intervention, and what adaptations might be needed in order to make it feasible to deliver it in Kenya, Tanzania, and Zambia. And so obviously the first thing that they had to do was translate it out of English and into Kiswahili, which also meant giving it a new name. So in Kenya, we call it Pamoja Tunaweza, or Together We Can, or that's the translation from Kiswahili. And then the three major things that we changed were, one, changing to a group delivery format. So TFCBT in the US is typically delivered in individual sessions. So we changed to a group delivery format. We changed the stories and the metaphors that we use to kind of convey the main principles or the core components of TFCBT. We changed those to match the Kenyan context. And then since we were working in group settings, we also added 2 to 3 individual sessions for each child in which we did the exposure-focused activities. And so there's a paper describing the adaptation process kind of in more depth, but one important thing to note, going back to fidelity and core components, is that we kept all of the key components of TFCBT. And so this gets into different levels of cultural adaptation. We kept all the core components. We thought that the components were culturally acceptable in the Kenyan culture or Kenyan context. And then we did like surface level adaptations to think about how to maintain the core focus, but just message them in a different way for this context. And one of the biggest implementation adaptations we made was that we would deliver in schools. So rather than working in community mental health centers, where much of our work had been in the US, we actually worked in schools. And the reason being for this is that there aren't as many community mental health centers. They do have psychiatric hospitals, but particularly, I mean, it's the same in the US. Kids are going to schools, schools can become a fixture in the community. And so we were on board with the education system and had our children receiving care in one classroom, and then the guardians participating in a concurrent group and another classroom. And we did have some joint activities, particularly towards the end of treatment. We would integrate the two groups during treatments. So this was all sort of the groundwork in the earlier phases. We knew that TFCBT would work and that it was acceptable in the Western Kenya context. And so the question became, now that we know that it works, how do we actually increase access to it? So to provide a bit of historical context, so in May of 2016, Kenya launched a national mental health policy, which sort of established mental health treatment as a focus in the country and provided some limited funds for it, but did provide some funds for it, which coincided with the end of one of our earlier research trials where we were looking at the effectiveness of TFCBT and really prompted us to consider as a research team what sort of natural systems, given the limited funds, but now that mental health does have a national policy in Kenya, what systems that are already existing can provide this service to youth, and what is needed for the successful delivery, scale up, and sustainment of TFCBT in these settings. So that sort of laid the groundwork for the basic study, in which we partnered with schools and the education sector to have teachers deliver a trauma-focused cognitive behavioral therapy. And then we also partnered with the health sector and had community health volunteers. So Kenya uses CHVs or community health volunteers. It's similar to community health workers in many other countries or in many other contexts. But in Kenya, they use CHVs. And so we had CHVs that we had trained and supported to deliver TFCBT as well. And importantly, because we already had strong evidence to suggest that TFCBT worked, BASIC was a primary implementation study. So we looked at the effectiveness of TFCBT, but our primary outcomes were really on what implementation strategies or what sort of implementation practice and policies was needed to support TFCBT and build a context that enabled TFCBT delivery. So put in a different manner, what do organizations or what do our schools and our health organizations need to do to successfully deliver, scale up, and sustain TFCBT, particularly in the Western Kenya context? And we thought that this was an interesting implementation research question because we were working across two very different systems. And so what our study goal was to actually compare across both systems. So in the prior work that we had done, we had trained teachers primarily, and we found that teachers were great at delivering an intervention. Teachers can teach very well, of course, but they have a lot of competing demands. They're very busy. They're doing other things throughout the school day. And so even though teachers may be an appropriate person to deliver, they may just not have the bandwidth to deliver an intervention. Whereas someone like a community health worker may have less formal education than teachers and may have less experience delivering content in the same way. Um, but they may have more flexibility in their time. And particularly if a health system were going to support their time, there may be more flexibility in the way that their time is used. And so we were really interested in trying to understand across these two different systems and across these two different provider types, what was needed to ensure that we could successfully deliver the treatments. And BASIC was informed by Brian Weiner's implementation effectiveness theory, and I could be misremembering this name of this theory, but it's by this wonderful scientist named Brian Weiner, who is one of my mentors. He's at the University of Washington. And basically, the theory behind the study suggests that in order to effectively deliver an intervention, a number of things have to happen. So the organization first has to be ready to implement an intervention. So is the organization, whether that be a school or a health organization, actually encouraging, supporting, and rewarding the intervention delivery? If they are ready to implement an intervention, they must provide some level of support for that intervention. So they must have enabling implementation policies and practices. These are things like supervision, like providing a space for the intervention to occur, having a workforce. And so um, there has to be policies and practices, which then intersect with the implementation climate, the extent to which, people actually receive the intervention well, how well the intervention fits in with the values of any given system. And all of these things go on to impact implementation effectiveness. So if you aren't receiving adequate supervision, you don't have chalk to write on the chalkboard to deliver the intervention, then you are unlikely to be able to implement it well, which also means you're unlikely to see the clinical gains that you would hope to see from the intervention. So what we tried to learn across the basic study was to really focus on the front end of this. So do our interventions actually, or are our organizations ready for the change? Do they encourage, support, and reward the implementation of TFCBT? And what is the variance in that across different settings, across different schools and health organizations? And then what are these policies and practices that have to happen across settings in order to ensure that TFCBT can be delivered effectively? So, the primary aim of the basic study is to identify implementation policies and practices across 40 schools and 40 communities that predicted TFCBT adoption, fidelity, and eventually sustainment of the intervention. So, this is a 5-year grant, and at the end of year 5, we wanted to look at what percentage of the communities were still delivering TFCBT even after we were no longer actively collecting implementation or clinical data. One of, in my opinion, the innovative approaches that the basic study used was taking a coaching approach, where we took a phased adaptation approach and we had counselors and leaders from experienced sites providing coaching and support to subsequent sites in their implementation. And I'll talk a little bit more about that in the next slide. And then we also examined child outcomes and cost in each sector to do a cost effectiveness analysis. And then the goal at the end of the study was to treat over 1,000 children ages 11 to 14. We recently concluded data collection, and I believe our final analytic sample of children was around 861 kids across 40 different communities and 80 different implementation sites. As I mentioned, they took a coaching approach. So we started and staggered implementation. So we had 10 village clusters. So we trained 60 clinicians originally to deliver the intervention here in sequence 1, and we let them implement for about a year to see how things went. At around this point here, the start of year 2, we took a pause and asked our clinicians in the first clusters to reflect on how things went. And so, how did they feel like implementation went? What needed to happen in order for them to actually effectively implement the intervention? What, again, were those implementation policies and practices or implementation strategies that supported them to deliver TFCBT? And so we convened what we called the BCT, or the Basic Collaborative Training, where we actually put all of this data together and developed a coaching approach where our counselors from sequence 1 were then employed to help the counselors in sequence 2 deliver or sort of kick off their intervention. So we developed a coaching guide where the counselor said from sequence 1, what was really important for me was I never would have thought about this before, but I needed chalk. I needed a principal to tell me I could take chalk from the supply room. I needed my principal to tell me that it was okay that I didn't oversee the kids leaving that day, and I had a workload adjustment so that I could provide the intervention. And, thirdly, it was important that I had airtime on my phone so that I could reach out to guardians when they weren't showing up. And we basically just created these checklists where our early counselors could go in and say to folks before they started delivering in the later clusters, hey, this is what helped me. So I'm telling you now so that you can know before session one, oh, you should think about where to get chalk and you should think about asking for a workload adjustment from your principal. And so what we're able to do across the study is to track potentially the difference in early effectiveness or early implementation outcomes by looking at something like this coaching approach. And then also we're sort of, building capacity for doing almost like an coaching or facilitation model across the different sequences. To tie it back to supervision, because of course that's the focus of what a lot of my work has been on, all of our supervision was provided by trained Kenyan like TFCBT certified even Kenyan supervisors. So our 5 supervisors that worked with us across the trial and are pictured here led all of the training that we provided to all 60 counselors across the study. And they also led all of the supervision. So initially, this included face-to-face meetings, but as we grew and grew our number of supervisors, this became increasingly infeasible, and so they became also increasingly reliant on ad hoc mobile phone communications. So, which begged the question, and this was also sort of conveniently around the time of the COVID-19 pandemic, how can we really lean into mobile phones and supervision? And if supervision is one of these policies and practices that we think is required for TFCBT delivery, then how do we also make supervision more accessible and more pragmatic? And so mobile phones could be one way to do that by supporting providers from afar, reducing costs and travel time. But also, there are these contextual limitations and user preferences that come into play when working with mobile phones. I think, particularly in a global context. And so, one offhand example is that we probably all on this call today have unlimited data plans, and we don't really have to think unless we're going, somewhere really far off of the main roads. We don't really have to think about where we have cell service. Cell service, I think, connection across the US has really expanded recently. But when we were working with our providers in Kenya, they would tell us that, no one really has unlimited data plans. And so they have to purchase data bundles or airtime for all of the interactions they're having, which means that, they're not just going to call up their supervisors to just chat and have a quick check-in because that literally comes directly out of the money that they're paying for their phones. Similarly, many of our schools where we were working actually didn't have reliable cell signals. And even folks that did have more reliable cell signals in the places where they were delivering, it would be impacted by weather or power outages. And so we had to think really creatively, or there were just a variety of contextual limitations around how we could even use mobile phones. And so I present that because I think there's always so much interest in using mobile phones and mobile apps. And it is great for some, but maybe not the perfect solution for everything, at least not at this point. Or if it is, I think it still requires a bit of implementation science to think about how do we use mobile phones effectively. And so the first thing that we were interested in and looking at in the basic study is to really understand in a systematic way what are all of these contextual limitations that might come up in mobile phone use, and what is the acceptability of even using something like mobile phones for clinical supervision. I think, again, we're asking community health workers and teachers who have no formal training in mental health interventions to deliver a trauma intervention to kids, something that we know is difficult even for trained mental health providers in the US. And so, do they even want to receive supervision from their mobile phones? What are their thoughts on that? And so in order to do that, or in order to ask this question, we did a qualitative research aim first, where we asked our counselors, both teachers and community health volunteers, as well as supervisors, about how they used mobile phones. And we intentionally balanced folks that used mobile phones with low, average, and high frequency so that we could ensure we were really getting the broad sort of span of users and not only asking folks that were otherwise like really tech savvy people or who, lived in areas of high connection. And then we did semi-structured interviews with them and coded the data using a thematic analysis to understand acceptability and feasibility. And I'll just go through these pretty quickly because I want to ensure we leave time for discussion. So essentially, it was overall pretty acceptable. Folks liked using mobile phones for supervision, but there were a lot of challenges to its feasibility. So some of the bigger barriers to that were things like having limited resources. So again, for folks that were primarily or exclusively using prepaid phones, there was always an incentive to make the calls as short as possible. And even if we were providing airtime for the study and were giving stipends for airtime for the study, in this Western Kenyan context, any resources provided by the trial that weren't used on the trial would also just be used by them personally. And so there was still an incentive, even if everything was covered, to keep communications brief because that meant that their other money could go further. And so that was one big important consideration. Another important consideration, as I mentioned, was technical difficulties and network connection. So network connection was sort of an expected barrier. Another thing that emerged out of the interviews was technical difficulties and just how often people lose phones or get new phones or have phones that have to be charged every so often, but also don't have a place where they can reliably charge their phones at home. So they have to kind of work within the confines of when they can get somewhere to charge their phone and then, the X number of hours after that when it can hold a charge. And then beyond this, I think this is especially important, and you can imagine in relation to the last study, there are only so many activities that can be performed over the phone. So the STEP study in particular looked at behavioral rehearsals or role plays as one strategy that we know is effective to improve the quality of care that's delivered, but it's hard to imagine doing a role play fully just over a phone call, um, especially for something like delivering a group where you're trying to manage perhaps 8 children in front of you. There are things I think that you can role play, but a lot of our supervisors in particular weren't very comfortable with only providing mobile phone supervision because they wanted to see what clinicians looked like at the front of the room and how they engaged a large group. So, given all those barriers, we also asked, well, what can we do? What is feasible, and how do we make this work in a way that you would feel comfortable with? And so, what we found in this study is that the supervisors and clinicians generated 27 distinct strategies that they felt could improve mobile phone supervision. And the next question became, with all of these different strategies, how do we actually put that into practice? I think this is another common challenge with implementation research, where we often do a lot of qualitative work at the front side of a study or at the end of the study, and we learn all these great things. And then we struggle to think about like how do we actually put that into practice? Like having 27 different strategies doesn't lend itself well to a randomized trial where you're like trying to randomize between two conditions. And so one of the things that we tried to do was think really flexibly about how do you integrate like a rigorous approach that allowed for some flexibility and tailoring within these strategies, but also enabled some sort of rigorous evaluation. And so what we did for that, and this was guided by human-centered design, so we actually held a co-creation session where we presented back to our counselors and our supervisors these 27 different strategies intended to improve mobile phone supervision. And we engaged them in a lot of human-centered design techniques where we asked them, okay, so if this is the context, this is what other people are suggesting. How would this work for you? Can you imagine what would it be like if you were trying to provide supervision and so and so's phone network cut out in the middle of the call? Or how would you preempt knowing that they may not have service at their school? And what does that mean for how you would schedule your supervisions, things like that? So we were on site for a day. We actually had our supervisors lead all of this. And so this was a sort of informed by human-centered design, but also entirely Kenyan-led. We wrote a paper about kind of like what that process was like and the methods of applying human-centered design to this. And what we came out of that day-long workshop with was this flexible, almost like an implementation coaching plan. And I think this was informed by the approach of the study, the overall study, where counselors really liked this method of someone coming to them beforehand and saying, hey, these are the challenges that I faced, and here's what you can do to preempt those coming up for you. And so we took a similar coaching approach just for supervision in the end, where we developed these workable guidelines. Started off by just drafting them out on paper and then turned them into a paper document that was printed and distributed to all of our supervisors and our clinicians on sort of on the ground. Um, where they just problem solved together. They presented the challenges that they had had and said, a lot of times other counselors have felt that they didn't get all the information that they needed because they didn't have their phones, or one person got the message but not the other people, or they didn't have enough airtime. And then they just decided as a group of clinicians what strategies they felt like would work for them. And these were all super low touch, low intensity strategies like creating text groups or SMS groups, having counselors like send a free please call me message to their supervisor so that the supervisor would call them back and then the supervisor's phone would be charged, but not the counselor's. So these very low intensity strategies that required no additional resources from us, but were very easy to implement. And then again, as I mentioned, this is sort of in line with the coaching approach. So they just had a very brief visit where someone from our study team, it was actually the supervisors that led this, would go out and introduce these guidelines to the counselors before they started delivering the intervention. And then that is sort of what we evaluated in the end. So just the idea that we could print a piece of paper and do a bit of problem solving before we ask someone to start implementing the intervention. And then what was the effectiveness of that on our key implementation outcomes. So how this all kind of fell in the grand scope of the trial. So we engaged counselors from the first 5 sequences of the basic trial to develop our mobile phone supervision guidelines. And then all of the development happened during sequence 6. And so this was when we did all of our interviews and when we did all of our workshops and planning. And then they were ready to be implemented in sequence 7. So that was our sort of intervention group, which was compared against our sequence 7 group because they neither participated in the development nor did they receive the guidelines. We evaluated in a mixed methods approach that included both qualitative and quantitative data to sort of explain any findings that we saw. Quantitatively, we looked at acceptability. So did folks like mobile phone supervision? Feasibility, was it possible or feasible in their setting? And then usability. So was it actually usable? Was it possible for them to use it, which is similar to feasible, but sort of a new emerging implementation construct. And then qualitatively, we did a thematic analysis to describe the effects of the approach. So what about receiving these guidelines and having an outreach visit and receiving some coaching around it made it such that this was, if it was, more acceptable, feasible, or usable? And all this coding was led by supported by 2 of my students at the University of Washington, Lucy Liu and Jacinto Silva. So what we saw was that guidelines were associated with improved acceptability. So folks that received the mobile phone guidelines were more rated mobile phone supervision as more acceptable. There was no evidence of a difference in feasibility, which I think makes sense. We didn't actually address any of the structural barriers that made it so that mobile phone supervision wasn't that feasible. Like the power still went out in these settings, and we were not able to improve mobile network connection in these communities. So we didn't actually address feasibility at its, the core of what the construct is, but you can see that there are some differences in just distribution of the feasibility scores between the two sequences. And then finally, we found that guidelines did improve the usability of mobile phone supervision. So suggesting that it was more usable for folks to actually work within the confines of their context to use mobile phone supervision. Qualitatively, we found that just having these brief meetings helped set expectations around what supervision was. I think that it's easy for us or for our research team, which was primarily clinical psychologists, to forget that for a lot of people, they don't have experience receiving or providing clinical supervision. And so for our teachers and our community health workers, having these brief meetings up front to just explain, like, this is what we'll do in these meetings, and this is why it's important that you attend to them fully, was a very helpful aspect of having even just this brief light touch support. And that since it emphasized the importance of clinical supervision and also it as a space where they could get both support on the intervention, but support for their own mental health. Many folks mentioned that it was helpful in helping them learn new strategies to deal with the challenges that they faced in receiving supervision. And then it also increased counselor comfort, both with supervision, but also with the intervention itself. And so, a couple quick discussions and conclusions. So mobile phone supervision we found was acceptable, yet of course there are key challenges and user preferences to be considered. And these co-developed implementation guidelines and outreach visits were associated with improved acceptability and mobile phone supervision and usability of mobile phone supervision, but highlight the need for pragmatic and flexible implementation supports. So the takeaways, I think, from this study are really, or I'm curious actually, what are the takeaways that you all think about from either this study or in relation to supervision, clinical practice, or anything like that that maybe will inform what you do after this? Yeah, Liz.
This was super fascinating. Thank you so much. So I would say just I mean, I loved the co-design session with people about the things that they see as ways to improve supervision and then incorporating that. That was beautiful. And I don't know, like for me, the takeaway is just people have the answers. We just need to ask what they think. And then the ideas are right there. It's great. And they were really feasible to implement, it sounds like. So that's kind of one key takeaway. And then I think too, just being flexible in the delivery of whatever the intervention is, like being able to think about the context and what makes the most sense for that context. So like shifting to group, I think there's a lot that's helpful about group, like you're serving more people, but also there's like a beautiful thing that can happen in a group context with survivors and with parents of or supporters of survivors. And so that was kind of like a, cool thing to see that was an additional piece in your Kenya work.
Yeah. Any other reactions? I wonder if I don't want to pit any of the trainees on the spot. But I'm curious from anyone else that maybe is kind of interested or has a question about the either of the studies, really. And I guess I'll also say, oh, Lauren, yeah.
Hi, Dr. Triplet.
Hi.
My what I will take away is quite similar to Dr. Aparicio's. I have been in that situation, working in rural communities in Nigeria, where we had to work with community volunteers, and I was one of the people actually supervising the community volunteers who were also supervising a lot of the intervention groups. And one of the big challenges we had just it's one thing to wrangle the participants themselves, and it's a different thing entirely to have to wrangle the community volunteers as well. So I really like that idea of of strengthening that participatory approach by also involving them in some of the planning and also even giving them helping them build that capacity to be able to anticipate challenges that they might come across, that they might have when they are supervising the actual groups for the receiving the intervention. And that was one of the biggest things that I caught from what you said. And I think the other thing that I had for follow-up, and I did not know because apologies, I joined a little bit late. One of the challenges that I had experienced personally beyond um, feeling that the community volunteers might not have been able to appropriately ensure that the intervention was being delivered in the at the group level is the is in finding that balance with what are the needs in the community, what the community volunteers they believe for themselves. It's often it tends to align because they're from the community. It tended to align mostly with what the group participants also believed. And there wasn't always that motivation to insist on the material or to try to um, teach the intervention or put forward the intervention in a way that would dispel those myths because they also had a very strong belief for the myths themselves. So that was one of the challenge that kept occurring while we were doing that intervention. It's just something that I had remembered. I did not know if that was also something you experienced and if just having those meetings where they were also involved helped to address issues like that.
Yeah. No, that's great. Well, one, I'm like so excited to hear that you kind of have experience even doing the supervision yourself and kind of seeing firsthand what that's like. I think that's such valuable experience. And I'm sure informs so much of like your take on research. I think that I actually haven't. So this is a plug for, all BCH or non-BCH students as well. Um, the data for this trial is now fully mature, and the main outcomes are underway, which means, and I've already done the hard work of getting a data use agreement between my previous institutions and Maryland. So if folks are interested in particularly this basic study in Western Kenya, we have a lot of data and a lot of really cool implementation data, which I think is pretty rare to have like 40 different sites that you can compare implementation data across. So if folks are interested in that, I would love to, start working through that with some students. And I can promise you the collaborators at Duke and Washington are both incredibly lovely and would love to have people from Maryland support some of that writing too. But I will say, so I haven't looked at the fidelity data. So this is not a quantitative data informed response to you. But qualitatively, I think what we heard and what I saw in just like the sessions that I would listen to or observe when I was there is we almost had the opposite problem of where I think that we ran the risk sometimes of our interventionists being a little too by the book, such that it kind of felt robotic at times. And so I think we had to work a lot. Our supervisors had a lot of really great metaphors about like, our intervention is the recipe, but when you make the recipe at home, you don't like just follow it to a T. Like sometimes you add in a little extra pepper or you add in this like spice that you wouldn't have otherwise. And so we had to work a lot on empowering our clinicians to, have flexibility within fidelity to the intervention because otherwise I think that there was a real tendency to just read. And so we had great fidelity, but it was like there was a risk that it was just like our participants were getting lectured to. And so I think that was one of the interesting things. And it's probably because of, we did have a fair amount of community buy-in. And I think people really saw supporting child survivors of traumatic events as like it was something that they were really invested in. But I think because it was aligned with their needs, we also then found ourselves in this weird setting where like when you think about like what makes for an engaging group, they were delivering all the content, but it may not have been that engaging because it was like very didactic and very lecture heavy. And so yeah, but I think that that goes back to what you were also saying, Lauren, of ensuring that you're meeting the community needs and understanding what the community is wanting from you as well. And so, um, yeah, it's sort of like a double-edged sword also, though, especially, and I think part of like we can't ignore the power dynamics too of like a bunch of US researchers coming in and saying like, oh, this is the intervention that we think will help you. And so I think that I mean, it all plays a role, but um, yeah, I think it will be interesting to look at our fidelity data more broadly and see, what was our fidelity like and how does it relate to our outcomes in this study as well? Any other questions or reactions from folks? Yeah, go ahead.
I had another question. Or I guess I have a question versus a reaction before. I'm wondering if you all have thought about using any sort of like AI facilitated support in between supervision sessions or anything like that, kind of where you are with those potential options.
Yeah, so we hadn't thought about that as much for this trial, and it's interesting. Now that I feel like, AI is so, well, to me, who's not a very techie person, it feels so new. It's like all come about in like the last couple of years. And so when AI really hit the scene, a lot of the active data collection for this trial was done. And so we had thought about other like lower tech ways to build in support in between supervision sessions and thinking about using WhatsApp more and group messages and things like that. Um, but for this study, we hadn't thought as much about AI. I do feel like it would be interesting to try it out. I think the Kenyan context would be, yeah, it would be an interesting use case in just like how do you do a lower tech version? So for a lot of our folks that don't have smartphones, how can you still use an AI support even if it's just like delivered via SMS or something? And again, I don't know enough about AI to know, but one thing that we have thought about, which I'm particularly interested in, given that we have this like massive stockpile of recorded session data and recorded supervision session data, is how to use AI to guide, like as a fidelity tool, essentially, and like giving AI or like large language models some of the recorded sessions to start thinking through like improving fidelity. The clinic at the psychology training clinic at Washington actually has AI integrated into their like recording platform that they do telehealth sessions on. And so when I was supervising students over there, I would get a report at the end of the session where AI would tell me like so and so clinician used 15 empathetic remarks in their session. And so it would like give you kind of fidelity, but also just like interesting other qualitative breakdowns. And so I do think there's a lot of potential for AI. And I'll be really excited to see, especially for these like lower tech settings, but how it can be used. But also, as I say that, I'm mindful that like tech is evolving so rapidly that I think that even now our supervisors and our clinicians have more resources and better phones than they did 4 years ago when I was doing my dissertation. So it's also catching up quickly.
I'll jump in with a question. You mentioned earlier that you noted qualitatively that folks almost were using too much fidelity, sort of robotic in regards to following out the training. Have you had conversations or thought about conversations with individuals about what fidelity means to them and sort of where they do have some wiggle room and where they can components that are required and then areas where they can embellish or adjust as needed.
Yeah, I think that they did have some of this conversation, and that became a focus of the supervision of thinking about like how do we help them learn like what are our core elements and what are the things that they can tweak off of. And so what we ended up developing in the end were I think we called them cheat sheets. I can't remember. Step sheets is what we called step sheets. So we had play-by-plays for each session that would have the core component kind of bolded and then would highlight areas where they should feel free to adapt a little more or integrate their own stories. And so we tried to do it in that way. And then what that reminded me is that sort of related to this, it didn't come up in the context of supervision, but one thing that we did was actually like even the concept of fidelity is like made up implementation language. And so my advisor actually wrote a paper where I think fidelity was one of the constructs that they looked at. They actually like asked folks in Kenya like, well, how would you describe the concept of fidelity, not in the like not using the word fidelity. And so that I think is a like was a really important process to go through with our folks over there as well to be like, how do we make sure that we're all speaking the same language and it's not just like our implementation researcher language we're imposing on you, but like, how would you describe something like acceptability, you know? Um, and so, yeah.
All right. Well, we have some closing. I don't know if you had any other pieces you wanted to say, Dr. Triplett, but
For me.
we had a couple of just closing things to talk through. First, just wanted to introduce our Deputy Director at the Center for Prevention Research, Dr. King. So I'll turn it over to you.
Great. Thanks everyone for attending. Dr. Triplett, I really truly appreciate it. I've learned a lot. And thank you everyone for being and attending in this session. We do have an evaluation survey that we're going to drop into the chat function and we'll follow up on email as well. So we appreciate you taking a minute or two to complete that. I also want to remind everyone that Dr. Triplett is our first in our 4th seminar. So thank you for jump-starting us. We have Dr. Akala, which is on December 5th, Friday, from 2 to 4, Dr. Peitzmeyer in February, so bringing us into the new year, and Dr. Bishop in March. And we'll be also, again, following up with sending new emails. I hope everyone has a fabulous rest of their afternoon. Happy Halloween. Enjoy some candy if you get the opportunity, and have a great weekend. Thanks, everyone.
Thanks so much. Take good care.
Thank you. Take care.